Good day. I'm Ann Casson, and I'm one of the fertility nurse specialists at Memorial Sloan Kettering Cancer Center in New York City. I'm honored to have the opportunity to discuss fertility and fertility preservation in the setting of Fanconi anemia. I hope this talk offers some general guidelines for you. At the onset, I want to disclose that fertility is an understudied aspect of FA and deserves further attention in the future. We will review the biology and impact of FA on fertility, options for fertility preservation, family building options including biological and third party, and I will end by reviewing some resources with you. We will start with a brief overview of male reproductive biology. During embryonic development, the primordial germ cells are responsible for gonad development. They are the precursors of the gametes, or the precursors of what will become sperm and eggs. This is a cross-section of a testicle where sperm production takes place. Sperm production takes place deep in the testicles and the seminiferous tubules with these tiny cells called spermagonial stem cells. These spermagonial stem cells not only regenerate but give rise to a spermatocyte. The spermatocyte will go on to become mature sperm as it moves through the seminiferous tubule and into the epididymis. Of note, males do not make sperm until they reach puberty and start producing the hormones needed to allow this process of sperm maturation to take place. Many males with Fanconi anemia have a marked reduction in fertility, and there is some evidence to suggest that there may be a decrease in differentiation of those primordial germ cells during fetal development, leading to hypogonadism. Males with Fanconi anemia may have few or no spermagonial stem cells, which would lead to few or no sperm. Another name for this is Sertoli cell-only syndrome, where only the Sertoli cells are lining the seminiferous tubules. There's no sperm in the seminiferous tubules. What is not well documented is if males with FA have the spermagonial stem cells at birth and lose them, or if they never had them. So although the FA pathway is well described for its role in DNA repair, the link between this and fertility is not well described. What are the options for our prepubertal males? If a prepubertal male is not receiving gonadotoxic treatment, there is no intervention at this time. Prepubertal males that are undergoing gonadotoxic treatment or a stem cell transplant regimen might consider testicular tissue cryopreservation. This is an experimental option for fertility preservation for prepubertal males. What exactly is testicular tissue cryopreservation? Again, it's an experimental option for prepubertal males where under anesthesia, a small piece of testicular tissue is procured for freezing. And it is hoped that this tissue will contain spermagonial stem cells that will be used for future fertility. There are two main avenues of research going on with prepubertal testicular tissue. The first avenue of research is after reaching young adulthood, reimplanting that tissue back into the testicles and allowing those spermagonial stem cells and spermatocytes to mature into sperm that are then collected for IVF. The second avenue of research that's being pursued has researchers trying to grow the spermagonial stem cells in a lab with hopes of being able to reinfuse them back into the testicles at a later date and reinstating fertility. Both of these, again, are experimental and there have been no live births to date. However, a monkey was born by the reimplantation of tissue and sperm collected for IVF. This was an exciting development at the University of Pittsburgh as it can open the way for human studies in the future. Some of the risk with experimental testicular tissue cryopreservation includes there's always a risk of reinducing disease cells back into the body. So you would want to be in remission when you are procuring the tissue. And we have to always take into account the patient's counts when we're considering testicular tissue cryopreservation. It is a surgical procedure, so you do want the platelets at a reasonable level as well as the white count so that you don't have additional risk of infection or bleeding. Lastly, insurance does not usually cover this since it's experimental. At our institution, we always try to combine testicular tissue procurement with another procedure to try and keep the costs down. Depending on your institution, it may cost several $1,000s for the surgical procedure itself. Once the tissue is procured, it's sent to a cryobank where there will be annual storage costs as well, and this can usually be between $200 and $600 annually. What are the options for fertility preservation for postpubertal males? Again, postpubertal males that are not receiving gonadotoxic treatment, there's no intervention needed. Postpubertal males that are going to receive a stem cell transplant and receive gonadotoxic treatment should try to sperm bank prior to starting therapy. Sperm banking needs to be done at a licensed andrology lab where sperm is collected by masturbation and frozen for future use. We always recommend, if time allows, that 3 collections be done prior to starting treatment, as it allows for more family building options in the future. In our tri-state area, sperm banking can cost between $500 and $1,000 for all 3 collections, and then the annual storage fee is somewhere between $400 and $600 a year. Insurance may cover this in the setting of facing gonadotoxic treatment, but we have found in general most do not have coverage still. Some men with and without Fanconi anemia are found to not have sperm when they go to the sperm bank. Again, in the setting of Fanconi anemia, this may be due to few or no spermogonial stem cells. For these men, they consider trying to have a TESE or testicular sperm extraction done. This is a procedure done under anesthesia where testicular tissue is taken from deep within the testicle in the seminiferous tubule, where that tissue is then taken to a sperm bank and examined for sperm. If sperm are found, they are frozen for future use. We have found that insurance typically does cover this procedure. What are some alternative family building options? Third-party reproduction with donor sperm. Donor sperm is often used for family building. It can cost somewhere between $600 and $900 per vial, and usually 2 vials are needed per attempt of family building, whether it's intrauterine insemination or in IVF. Adoption is also an option. Typically, adoptive parents need to be cancer-free for a few years, and they will need a physician letter stating that they're in good health. Now I'm going to end by just reviewing some resources that are available for family building. A lot of these centers either have offer support and counselors, or in some of them offer financial assistance. The Family Building Center offers counselors, stress management, and just help navigating the fertility process. Cancer Finances, Gilda's Club, and Livestrong also help to manage medical expenses and provide navigating kits for finances. Gilda's Club has multiple locations across the country. We have the Patient Advocate Foundation, Expect Miracles, and SAM funds, which provide both financial grants and family building grants. Reprotech, Vernus Purse can provide cost-effective long-term storage. Team Maggie and Fertility Within Reach also offers assistance for family building. I hope this was helpful and gave you some good resources for the future. Thank you.